First of all, let me thank the extracorporeal group for giving me this opportunity to present. Um, so we'll directly go to the topic. So we know that diabetes is one of the most common causes of chronic kidney disease and end-stage renal disease in the world. And whenever we come across a case of diabetic kidney disease, we try to retard its progression. And to do that, we have different pillars available. And the problem when a clinician face while instituting these pillars, the pillars being AC inhibitors, ARBs, SGLT2 inhibitors, mineralocorticoid receptor antagonists, when we add these drugs one by one, the problem that we commonly face in certain group of patients is a resistant hyperkalemia. So, and when the hyperkalemia occurs, it leads to treatment inertia. We reduce the dose of what is actually required. We avoid certain drugs. And finally, what happens is the CKD, DKD progresses. So it is important that we understand hyperkalemia, especially in diabetic patients. Hyperkalemia can be due to insulin deficiency per se. A patient who is having high blood sugars and insulin levels are very low. In such patients, the potassium will not go into the cell, and that itself can trigger hyperkalemia. And also, most of these patients might be having chronic kidney disease, which can contribute to hyperkalemia. They are also on a cocktail of drugs from different departments, cardiologist, the nephrologist, the physician, and all these can again trigger drug-induced hyperkalemias. Some of them might be on herbal remedies, other Ayurvedic preparations. So all these contribute to hyperkalemia, and of those, type 4 renal tubular acidosis is important because if we correctly recognize it and manage it accordingly, we will be able to execute our pillars of management better. So, as the name itself suggests, type 4 renal tubular acidosis. We assume that it's a tubular disorder, especially seen in patients with chronic tubular interstitial diseases like analgesic nephropathy, obstructive nephropathy, sickle cell. But no, in spite of being a glomerular disease primarily, diabetes is the most common cause of type 4 RTA. And 50% of the patients who are diagnosed with type 4 RTA are actually diabetic patients. So you can see that the diabetes as a cause of type 4 RTA is very prominent, though we think that it is rare. So before going into that, we'll just go through the basics. You know, the renin-angiotensin system. And here the key factor is renin, which comes from the kidney. And it is the renin which brings about the changes and helps in the formation of angiotensin 2, aldosterone, etc. So where this renin comes from? So this is a schematic diagram. We know that there is a area called the juxtaglomerular apparatus where renin secreting cells are there and they secrete renin. But what happens in diabetes? This is a biopsy finding of a diabetic patient. You can see this very hyalinization which is happening in the efferent arteriole. So this hyalinization in efferent arterioles causes atrophy of this juxtaglomerular apparatus, thus giving rise to low levels of renin from the GG cells, causing reduced levels of aldosterone and other downstream markers. So in diabetic nephropathy, because of this arteriolar hyalinization, you have a low renin in them in general. Not only that, diabetic patients are prone to develop hyperkalemia due to low renin because they already are on a volume expanded state and there will be high levels of atrial natriuretic peptide, which itself decreases the renin secretion. And also the chronic hyperglycemia will lead to autonomic diabetic nephropathy, and that can cause decreased conversion of renin to active renin, and also its action on beta adrenergic receptors. Because of these various reasons, diabetic patients are prone to develop a low renin state, which ultimately gives rise to a low aldosterone and what we call as hyporeninemic hypoaldosteronism, which leads to chronic hyperkalemia. So before discussing, we have to know about this particular segment of nephron, the collecting duct. The collecting duct is important, especially in a case of type 4 RTA, because the final changes in potassium homeostasis occur here. And you can see that the two main cells of the collecting duct, the principal cell and the alpha intercalated cells. The principal cells have epithelial sodium channel, the ROM-K channel, and the sodium potassium ATPase. The principal cell has an intracellular receptor for aldosterone, mineralocorticoid receptor. So whenever this mineralocorticoid receptor inside the principal cell is stimulated, it stimulates the sodium epithelial sodium channel to absorb more of sodium. It activates the sodium potassium ATPase. So when this occurs, there is a lumen electronegativity which is occurring, which drives the potassium from inside the principal cell through the ROM-K channel into the tubular lumen. The same electronegativity makes sure that the H plus ATPase function and pumps in more and more of potassium. This leads to hydrogen. This leads to hydrogen excretion, potassium secretion, and at the same time sodium resorption. So what happens in a case of type 4 RTA? In type 4 RTA, either the aldosterone which has to be released is very low, or even if the aldosterone is high, there is decreased sensitivity of this mineralocorticoid receptor to aldosterone. This leads to decreased functioning of epithelial sodium channel, decreased functioning of ROM-K channels, and in the same way, decreased functioning of the hydrogen ATPase, causing a condition which leads to normal anion gap metabolic acidosis with hyperkalemia. One more thing that we have to be knowing is about ammoniogenesis. This ammoniogenesis is an important step which happens in on. This cell is the proximal tubular cell, and this is the alpha intercalated cells. This is the proximal tubular cells, and this is the alpha intercalated cells. So here, whenever there is acidosis, the body makes it a point to generate more and more of ammonia. The more the ammonia is generated, the better is the acid buffered, because we all know that the non-volatile acids can be titrated by titratable acids and as well as by ammonia. This ammonia generation occur in the proximal tubular cells. When this happens due to the deamination which happens of glutamine deamination, and glutamine deamination gives rise to ammonia, which is secreted into the proximal convoluted tubule, goes through the tubule, and comes out of the thick ascending loop of Henle, and then enters the alpha intercalated cells. So once it enters the alpha intercalated cells, it gets secreted into the tubular lumen, and thus it binds with the H plus ions which are secreted by hydrogen ATPase, and it buffers the hydrogen forming ammonium ions. This is a normal process which has to take place. But in case of type 4 RTA, due to diabetes, in type 4 RTA, because of the acidosis and hyperkalemia, the ammoniogenesis inside the proximal convoluted tube doesn't happen. Because of this, ammonia is not secreted, and acids are not buffered, and then thus lesser ammonium ions are formed. Though lesser ammonium ions are formed, we have to understand one thing, that is the hydrogen ATPase is still working and H plus is getting still secreted. So that is the reason why because of the presence of H plus in the tubular lumen, you usually find that the urine pH is usually less than 5.5, and which is not commonly seen in distal RTAs. So that is the difference between distal RTA and type 4 renal tubular acidosis, where the urine pH is maintained to less than 5.5. So next we will discuss a few cases. My first encounter with type 4 RTA happened during my MD days at Calicut Medical College. So this was a 60-something-year female with diabetes and a serum creatinine of 2.5. She was on ARBs and mineralocorticoid receptor antagonists, but she had an episode of acute diarrheal disease. She was found unresponsive, she was hypotensive, and she reached the casualty. Evaluation showed a potassium of 7.5. And this was her ECG. The ECG shows sine wave pattern, which is very classical when the patient develops hyperkalemia. very severe hyperkalemia. So this patient was managed in lines of septic shock due to a GI sepsis. So patient was treated as an acute kidney injury, acute on chronic kidney injury, which GI sepsis and shock. The ICU team took in, the patient was taken for SLED, and patient's rhythm came back to sinus rhythm as soon as that SLED was taken. The septic shock was treated, the patient became non-oliguric, but the hyperkalemia never recovered. The hyperkalemia persisted. We were not able to taper off dialysis for that patient at all. Whenever we tapered dialysis to 2 or 3 days, the potassium would jump to 6, 6.2, 6.3. Though there was no ECG changes, the potassium was persistently high. We adjusted the diet, we removed all ARBs, MRIs, everything was removed. Diet was strictly followed. We had to dialyze that patient for close to 1 month, even though he was pouring in enough urine. And even after stopping dialysis after 1 month, the potassium was always towards the higher side, 5.5, 5.5 range. So what I think that this case probably was a case of type 4 RTA, which was unmasked by an acute insult of GI sepsis. This was not just a case of acute on CKD causing hyperkalemia. The next case that I would have to discuss is a 65-year-old female who's a type 2 diabetic patient. She presented with fever, rigor, abdominal pain, abdominal tenderness. Her total count was around 23,000. The USG abdomen, because of the abdominal pain, when we did it, showed acute cholecystitis. So this patient was treated as a case of acute cholecystitis with GI sepsis. She was treated with IV antibiotics, but by day 5, though the patient was in improving trend, the patient develops diarrhea. And during that time, when the patient was fairly recovering, we found this pattern in blood. The patient's sodium was 132, potassium slightly towards the higher side. The patient was having an acidosis. So the creatinine was not very high, 1.3. So this is a case of metabolic acidosis. So whenever you get a case of metabolic acidosis, we check with Winder's formula whether or not the expected PCO2 is okay. And we found that the PCO2 is fine. So it's a pure case of metabolic acidosis with an anion gap was checked. The anion gap came as normal anion gap. So this is a case of isolated normal anion gap metabolic acidosis with adequate compensation with a borderline hyperkalemia. So another problem is whether this hyperkalemic, though the hyperkalemia is just evolving, whether this normal anion gap metabolic acidosis is due to the diarrhea or is there an underlying distal RTA in the background. So for that, to answer that, we need what is called as a urine anion gap. Now, urine anion gap is calculated by urine sodium plus urine potassium minus urine chloride. The usual values is usually negative. The urine anion gap actually indirectly measures the urine ammonia. So whenever there is a GI loss of bicarbonate, there is increased ammonium genesis in the kidney, which helps to excrete out or buffer out more and more of H plus ions. So in those cases, the urine ammonium will be high and the urine anion gap will be negative. But if the cause of normal anion gap metabolic acidosis is due to an RTA, then the there will be decreased ammonium secretion and the urine anion gap will be positive. So in this particular case, urine anion gap, when calculated, was found to be minus 35. So this case of normal anion gap metabolic acidosis was not due to an RTA, but was due to diarrhea, which has triggered a normal anion gap metabolic acidosis. So this patient's antibiotics were tapered and the diarrhea resolved, and patient's acidosis and hyperkalemia also resolved. So this shows that how urine anion gap can help us in borderline cases to decide the cause of hyperkalemia is type 4 RTA or is it a GI loss of bicarbonate. The next case that I would like to discuss is a 65-year-old male with diabetes. The patient is not at all on regular follow-up. This patient was admitted with urosepsis and the patient was recovering well with antibiotics, but the hyperkalemia was very stark, very persistent. Though there was no ECG changes, the hyperkalemia was very strong. Potassium of 6.3. Creatinine was not very high, 1.3. But when checked, whenever you come across the case of hyperkalemia, in the background of patient with the diabetes, the close thing that we always consider is whether this patient is having type 4 RTA, whether it's having an incomplete or a evolving type 4 RTA. So when the pH is checked, the pH is very close, very around 7.38. So a urine potassium was done. Urine potassium was 43. So in the phase of hyperkalemia, a urine potassium of 43 says that the potassium is not properly excreted. So this can be confirmed by another test called transtubular potassium gradient, TTKG. The TTKG estimates the ratio of potassium in the lumen of cortical collecting duct to that of the peritubular capillaries. It is found by the formula urine potassium into plasma osmolality divided by serum potassium into urine osmolality. Now, this TTKG, though it is not very frequently used, it is still of some academic importance. That's why I am discussing this. This is not relevant whenever the GFR is less than 30. The normal TTKG is around 8 to 9. So whenever there is a high extracellular potassium, the urine potassium should increase. That is the normal response. So when you check the TTKG for this patient, the TTKG came close to 4.9 only. So that means the potassium excretion by the tubules is not adequate. So this can happen due to two reasons. Either the aldosterone bioactivity is not able to keep in pace with the need of the hour of hyperkalemia, or the aldosterone is secreted, but it is not able to properly function because of the defective tubules. To differentiate between these two, we have to do what is called as a fludrocortisone challenge. So in these patients, we give a dose of 100 microgram of fludrocortisone, and after about 24 hours, we recheck the TTKG. When you recheck the TTKG, we find how the fludrocortisone has caused the effect. So in this particular case, when the TTKG was rechecked, it was still low, close to 6. So that means that it is not due to the absence of aldosterone, but it is due to the severe tubular damage which had happened due to diabetes. So with all these examples, you might have got a mild idea of what exactly type 4 RTA is. It is a normal anion gap metabolic acidosis. It is a hyperkalemic RTA. The urine pH is always maintained less than 5.5. And here, because of the acidosis and hyperkalemia, there is impaired ammoniogenesis. And usually this is seen in patients with a mild renal insufficiency. And this impaired ammoniogenesis translates into what is called as a positive urine anion gap. Then when you calculate the TTKG, the excretory power of potassium by the tubules, especially the cortical collecting duct, is low. So these patients will be having a low TTKG. So what actually constitutes type 4 RTA? So the usual term that we all have been studying and learning during our DM times is hyporeninemic hypoaldosteronism. It may not be always that. It can be due to a decreased responsiveness of the cortical collecting tubules also, where the aldosterone levels are actually more. And some authors consider drugs which interfere with the RAS system also as a cause of type 4 RTA. So nowadays, and also we all know that checking the levels of renin and aldosterone every time when you come across a patient with hyperkalemia and normal anion gap metabolic acidosis is not practical. Anyone who has done a plasma renin activity and aldosterone renin ratio knows that whenever you send a test, the test comes back after the turnaround time of the test is very long, close to 1 week. And that is the reason why this hyporeninemic hypoaldosteronism, that term is moving out. And new term called hyperkalemic RTA or a tubular hyperkalemia or just type 4 RTA is gaining pace. And of the renal tubular acidosis, mind you, type 4 RTA is the most common. And if you ask me the prevalence of type 4 RTA in diabetes, actually the literature is very sparse. Why do you think the reason might be? It is because mostly these patients are asymptomatic. And these patients manifest only when there is a potassium load or a drug or some form of sepsis which unmasks the type 4 RTA. And whenever that issue settles, whenever that acute event resolves, usually the potassium goes back to the normal ranges. So, and many a times we never do this renin levels or aldosterone levels while evaluating such patients. Because of these reasons, the prevalence of type 2 diabetes is still unknown. But there is documented evidence that about 43 to 63% of cases of hyporenemic hypoaldosteronism is seen in patients with diabetes. And there was a recent study from Germany which quoted that 3.8% patients admitted to their hospital was actually having type 4 RTA. Now, this is the last case that I plan to discuss. This is a 62-year-old male who came to your OPD with type 2 diabetes. And this patient is having hypertension. Patient is on telmisartan, empagliflozin, metformin. So this patient's blood workup is given here. So here you have an extensive workup of everything. The ultrasound KUB is showing was within normal limits, no obstruction. The patient was having a hyperkalemia. There is an A3 albuminuria present. Here the urine pH has been checked. The urine pH is 4.8. And based on these values, you can see that the creatinine is not very high, 1.2. The potassium is towards the higher side. Based on these values, what do you think? What is the most likely diagnosis? Is it a euglycemic ketoacidosis? See, euglycemic ketoacidosis, usually the patients are usually sick, not a patient who is coming to your OPD without any problems. And you can see the HbA1c also, it's very normal. And the blood sugars are stable. There is no severe, the acidosis is not very severe. So it's unlikely to be a type 4 euglycemic diabetic ketoacidosis. Can it be a hyperkalemia due to CKDs, DKD, G2A3? Very unlikely. See, the creatinine is only 1.2. With this creatinine of 1.2, a potassium was 5.6. It's slightly difficult to explain. Yes, it can be due to the associated ARBs and SGLT2 inhibitors, everything that you're giving, but still. Can it be voltage dependent distal RTA? So what is voltage dependent distal RTA? Voltage dependent distal RTA is a specific type of RTA that you see in patients with urinary tract obstruction. The urinary tract obstruction causes, so you can see this is when the urinary tract is obstructed, the distal flow of sodium to the distal nephron is impaired. So that leads to decreased secretion of ROM-K channels and decreased functioning of the H plus ATPase. So here you get hyperkalemia and also metabolic acidosis. Because the H plus ATPase is not functioning, the urine pH is usually more than 5.5. And this diagnosis can be easily clinched with a simple ultrasound of the KUB, which would show you features of obstruction like HUN or a stone or bilateral obstruction like that. And some of these, most patients will be having some abdominal pain. So in this particular patient, the USG KUB was completely normal. And above all, the urine pH is actually less. So yeah, this cannot be possible in a voltage-dependent distal RTA. Then what might be the cause? Can it be a hyporenemic hypoaldosteronism? See, this patient has been extensively evaluated. You can see that the plasma renin activity is towards the higher side. Aldosterone levels, though, it's on the lower side. So it's not hyporenemic hypoaldosteronism. So this particular case might be probably due to a type 4 RTA-like feature, which is due to a telmisartan, which the patient is already taking. That is when we have to know that a lot of drugs, especially drugs which we commonly use in patients with diabetics, are having features which can push them to a type 4 RTA kind of picture. Beta blockers, ACE inhibitors, ARBs, mineralocorticoid receptor antagonists, all these are commonly used by us in diabetic patients. And here you can see the different levels at which each of these drugs act to cause the so-called type 4 RTA picture in diabetic patients. So when you come across a patient with type 4 RTA, how will you treat them? Especially in diabetics. The first thing that you have to do is you should search vigorously for drugs which are causing a problem. Ask whether a patient is on any NSAIDs. Ask specifically for herbal preparations, because many of our patients are on herbal preparations for diabetes, and that itself can trigger hyperkalemia. Then you see what dose of ACE inhibitors or ARBs these patients are on, whether some dose adjustment can be brought about. All these things that you have to check. But what happens when you get overt hyperkalemia, severe hyperkalemia? Whenever that occurs, you have to go in line for the treatment of hyperkalemia. You can give calcium gluconate, can give anti-hyperkalemic measures, and ECG changes may or may not be there. And all these offending drugs which have caused this should be stopped. If the patient is on OHA and the patient is having severe hyperglycemia, it will be a good option to start insulin. When you admit these patients, you start them on insulin. The insulin has two roles. One, it controls the hyperglycemia. At the same time, it controls the hyperkalemia also. Most of these cases of hyperkalemia settle with conservative approach. But in some cases, as the case that I showed you before, heart blocks or sine wave patterns, and this hyperkalemia is life-threatening. In such patients who are not responding to the routine measures, temporary hemodialysis support may be necessary. But what about the proteinuria? We know that proteinuria control is of paramount importance in managing diabetic patients with diabetic kidney disease. So in that patient who is having type 4 RTA, what will you do? There is no doubt that RAS is fundamental in diabetic nephropathy pathogenesis, and without stopping the renin-angiotensin aldosterone system, the diabetes disease progression, diabetic nephropathy progression cannot be stopped. So for that, you need ACE inhibitors and ARB. There is no doubt about it. But in this group of patients with type 4 RTA, with a tendency towards hyperkalemia, you have to consider this group as high-risk patients. So what all can you do? So whenever you start a patient with a tendency towards hyperkalemia and diabetes on a RAS inhibitor, make sure that you have a pre-treatment creatine potassium GFR available. And you have to stop all other offending drugs which can add on to your hyperkalemia. Hyperglycemia itself is a factor, so you have to control that. So the KDIGO practice point in 2024 mentions that you have to review a patient started on ACE inhibitors and ARB every 2 to 4 weeks. So in this particular group of patients, make sure that you review them earlier. Review them at 2 weeks. And if the patients are not following up properly, don't add these drugs. And always start at a very low dose. If the patient is, you are planning to start on telmisartan, start at 20 milligram, or losartan, you start at 25 milligram. And always do a sequential addition of pillars. You know, that's RAS inhibitor followed by SGLT2 inhibitor, and after the next visit, you plan adding an NSMRA. So when you do the serial addition, the chances of the patient going in for hyperkalemia comes down. We all are very excited about the confidence trial, which had advised us to add SGLT2 inhibitor and NSMRA together. But this particular group of patient of type 4 RTA and diabetes, this is a high risk group of patient. And for this group of patient, better to add sequentially. Yes, it can give rise to treatment inertia, but it is better do no harm than treating and pushing the patient unnecessarily to complications. What about SGLT2 inhibitors and type 4 RTA of diabetes? See, SGLT2 inhibitors have the capacity to increase the distal excretion of sodium and water. So whenever there is increased distal delivery of sodium and water, it stimulates potassium excretion. And it is in the Fidelio trial, in the subgroup analysis of Fidelio trial, it was found that SGLT2 inhibitor addition was associated with lower risk of hyperkalemia. Though there is no definite studies in patients with type 4 RTA, close monitoring is required. But generally, SGLT2 inhibitor doesn't cause hyperkalemia in this group of patients. What about mineralocorticoid receptor antagonists? It is always better to avoid steroidal MRIs in this group of patients with type 4 RTA and diabetes. Try to consider finerenone in this case. You could try MRA, but it is more riskier. You would have to follow up the patient very carefully. So better than that will be to add finerenone, because finerenone is a more bulky molecule, lesser number of lesser chance of producing hyperkalemia in these group of patients because of the more specific action, bulky molecule structure, lesser tendency to produce hyperkalemia. And whenever the patient is having a potassium more than 4.8, better not start. And if also always ask for past history of hyperkalemia with ACE therapies. These are the patients who develop hyperkalemia with these drugs. And also always start at a lower dose of 10 milligram. and review after 2 weeks. After 2 weeks, if you review, the hyperkalemia which is creeping up can be diagnosed earlier. Another thing that you can use, diuretics, loop diuretics can be used, thiazide diuretics can be used. Another way of controlling is fludrocortisone. Fludrocortisone, the problem is it can give rise to hypertension, hypokalemia, and alkalosis, so it can be a problem. Then different types of resins are available, but the newer ones are more attracting attention. Sodium zirconium cyclosilicate. It is an oral non-polymeric formulation, but the problem with it is because it exchanges potassium with sodium, the chance of volume overload is always high. Similarly, patiromer is also coming up in a big way. So coming back to our case, this particular patient with hyperkalemia, you don't want to stop any of these drugs because it prevents retarding the progression of CKD. So what else will you do? Starting patiromer and monitor. Patiromer is not even available in India. And will you start insulin? This patient is having a very well controlled blood sugars with 5.8 of HbA1c. So unlikely. Will you stop telmisartan and monitor? No, better not stop it. So this particular patient, you can see that thiazide diuretic. When you add a thiazide diuretic, you will be able to control the hypertension, and at the same time, you will be able to control the hyperkalemia. So take-home message is, it is the most common form of RTA. The type 4 RTA of diabetes can cause challenges in diabetes who are having all these drugs. You should carefully look for a drug history and make sure that the GI causes are ruled out. Hyperkalemia and associated complications are ruled out, and urine anion gap and TTKG are things which are of importance in the clinical sense, but nowadays not used very frequently. Fludrocortisone can be used in resistant cases. Newer potassium binders are coming up. So that was about my topic. There are certain rarer forms of pseudoaldosteronism, hypoaldosteronism, but that's all.